All right, today we're going to break down a really critical concept you see all the time in the intensive care unit: respiratory failure. It's one of the main reasons a patient might need that high level of care, so getting a handle on the basics is absolutely key. Let's dive in. Breathing is something we do thousands of times a day without even a single thought. It just happens. But what happens when that automatic, life-sustaining process starts to break down? That's really the core question we're tackling today. That's when the simple act of breathing turns into a full-blown medical emergency. So, at its heart, respiratory failure is a failure of gas exchange. It's that critical point where your lungs just can't get enough oxygen in or can't get enough carbon dioxide out. And when that delicate balance is thrown off, the cells all over your body are suddenly at risk. It's like a major breakdown in the body's most important supply chain. Now, you might think respiratory failure is just one thing, but it's not that simple. Clinicians actually break it down into two main types, and it all depends on which part of that gas exchange process has gone wrong. The easiest way to think about this is like this. Type 1, which is called hypoxemic failure, is basically an oxygenation problem. There's just not enough oxygen making it into the bloodstream, and that means your body's tissues are being starved. Then you have type 2, or hypercapnic failure. That's a ventilation problem. The body isn't getting rid of carbon dioxide, so it builds up and makes the blood dangerously acidic. So how do doctors know for sure which type a patient has? Well, it's definitely not a guess. It comes down to very specific measurable numbers. This is where the diagnosis gets incredibly precise. The definitive test, the gold standard, is something called an arterial blood gas, or an ABG. And this isn't your regular blood draw from a vein in your arm. No, this sample is taken directly from an artery, which gives a perfect snapshot of the blood right after it's passed through the lungs. It gives us the hard data we need to make the right call. For type 1 failure, the number that matters is 60. If a patient's arterial oxygen level, that's their PaO2, drops below 60 millimeters of mercury, that's it. That is the clinical definition of hypoxemic respiratory failure. It's a clear, objective line in the sand. And for type 2, the magic number is 50. If the arterial carbon dioxide, or PaCO2, climbs above 50 millimeters of mercury, we know the body is holding on to way too much CO2. But there's one more piece to this puzzle. See, it isn't just about having a high CO2 level. It's about the effect that CO2 is having. And that's where the pH comes in. When the blood pH drops below 7.30, that confirms all that extra carbon dioxide is causing a dangerous acidic state. It's that combination, the high CO2 plus the low pH, that really gives us the full picture for type 2 failure. Okay, so we've got a diagnosis. Now what? The goal of management might not be what you think. It's not about finding an instant cure. It's all about supporting the body while the doctors scramble to fix whatever caused the problem in the first place. This quote right here just sums it up perfectly. Every single thing we do, from a simple oxygen mask all the way up to a ventilator, is designed to do one thing: buy time. It's about supporting the patient's breathing to prevent organ damage, which gives the medical team a crucial window to treat the root cause, whether that's pneumonia, an injury, or something else entirely. So the goals of management are pretty much the mirror image of the diagnostic numbers. It's actually really logical. For low oxygen, the goal is to get that PaO2 back up above 60. For the high CO2 problem, the goal is to correct that acidosis and get the blood pH back above 7.30. It's all about reversing those dangerous numbers we found earlier. So how do we actually reach those goals? Well, supportive care isn't a one-size-fits-all thing. You can think of it like a ladder of interventions. We start on the lowest, least invasive rung, and we only climb higher if the patient's condition demands it. And this escalation makes a lot of sense. You start simple, right? With some extra oxygen through a nasal cannula or a face mask. If that doesn't cut it, you move up to non-invasive ventilation, like a CPAP or BiPAP machine. That's a tight-fitting mask that actively pushes pressurized air into the lungs to help out. And if the patient still isn't improving, the final step is intubation and mechanical ventilation, where a machine literally takes over the entire job of breathing for them. So what are the triggers that force doctors to take that final, most intensive step? Well, there are several big red flags. If a patient just stops breathing, or if their breathing rate gets super fast and they just can't keep it up, that's a huge sign. If you can see their breathing muscles are exhausted, what clinicians call tuckering out, or if they're getting confused, it's time to step in. And of course, if the less invasive methods just aren't working, mechanical ventilation becomes the only option. All right, let's wrap all of that up. The The big takeaway is that respiratory failure is a breakdown in gas exchange. We've got type 1, which is all about low oxygen. That's a PaO2 less than 60. And we've got type 2, which is about high carbon dioxide, a PaCO2 over 50. The goal of treatment isn't a quick fix, it's to support the body and buy precious time. And that support escalates logically, from simple oxygen all the way up to a breathing machine. And that kind of leaves us with one final thought to chew on. We have come such a long way in our ability to support breathing when it fails. But this field is always changing, always evolving. So as we look to the future, the big question is, how can we innovate even more to better and maybe less invasively support this most fundamental of all human needs? Thanks for joining me.